Welcome back to the online portion of anatomy at Falcon Physician Reviews. This time we'll be moving on to placentation, talk a little bit more in detail of the placenta and some of the important fluids and fetal membranes. Let's start with a question. A 16-year-old female smoker and social drinker is diagnosed with a secondary metastatic cancer of the lungs. 2 months earlier, she was at the same hospital after stillbirthing a malformed fetus. What's the most likely cause of her cancer? In this case, the answer is C, incomplete hydatidiformal mole resulting in choriocarcinoma. Let's discuss this by looking at some of the things that are important in a molar pregnancy. These are high-yield points for your preparation in the USMLE. What is a hydatidiformal mole? Well, it's basically a malformed placenta which happens as a result of abnormal fertilization. And there's two basic types. There's the partial mole, which results as an oocyte and 2 sperm or triploid sex chromosomes, which would give you a chromosomal number of 69XXY. And this abnormal placenta will be produced, and there'll be some fetal parts recognizable because there's both male and female sex chromosomes present. The placenta will typically be small, and it will be accompanied by vaginal bleeding, typically in the first trimester, and often will result in a spontaneous abortion. The second type of mole is known as a complete mole, and this occurs when there's no female pronucleus, although the nuclear material is the same because the haploid sperm has duplicated its nuclear material to make a 46XX, therefore all paternal material. The abnormal placenta is present, but there is no fetal components. This oftentimes is accompanied by preeclampsia in that first trimester, has a very large uterine size with very quick growth rates, and the bleeding from the vagina is fairly heavy, and there's very high levels of HCG. One of the distinguishing features of these is that the placenta does not form proper villi, and they are kind of ball-shaped villi on the end, looking very vesiculated. And these oftentimes are what will continue on to become hyperinvasive, causing the choriocarcinoma. And that happens in about 2% of molar pregnancies. Now let's look at the placenta itself. We looked at it last time, discussing how it would implant at the polar end. It becomes covered with maternal materials from the endometrium, and then it will start to sprout villi. So it will form what's called a villus chorion, and the syncytiotrophoblasts will start to invade into the decidua basalis of the maternal surface. So there we have both the maternal and the fetal components which will make up the placenta. You can see a small secondary yolk sac, and the uterine cavity is starting to become obliterated as the fetus grows and the membranes that are surrounding it will push against the walls of the uterus. The amniotic membranes are formed by the amnion and the chorionic sac, which is actually the smooth chorion. This at one time was covered by villi, but as it grew through and pushed into the uterine cavity, those villi get flattened out and stop growing because they have nothing to anchor to, and they get no input from the decidua basalis, so they smooth out. These two layers together are what form the amniochorionic membrane that we oftentimes just call as the amniotic sac. The different components of the decidua parietalis get obliterated and will degenerate, along with the decidua capsularis, which is the component that is not near the placental implantation. This space of the amniotic or amniochorionic membrane will become filled with amniotic fluid, and we saw that starting to be produced at the polar end of the bilayered embryo. Amniotic fluid is an incredibly important component of successful pregnancy. It's typically a watery fluid with about 2% salts. It contains urea and some proteins with traces of sugar. It will be sourced both from amniotic cells of the fetus and also the maternal blood. And the fetal urine will be added to it after the kidneys develop and start producing a filtrate around the 4th month onwards. And this is an important thing for development of the fetus as well. So from that 5th month onwards, the fetus must swallow the fluid, and it will be absorbed from the gut and then passed on to the maternal blood for removal. They'll also inhale this fluid, which will help with the development of the lungs. And as there's amniotic problems, some of the red flag issues you'll have on question items in your USMLE Step 1 is going to be the issue of polyhydramnios, which typifies having more than 2 liters of amniotic fluid. These are often associated with multiple pregnancies as a normal consequence, diabetes mellitus as a pathological consequence, and oftentimes as well you'll get polyhydramnios if there are severe CNS malformations such as anencephaly or microanencephaly. And also you'll have polyhydramnios if there are GI problems because of an inability to swallow the fluid, where that will cut back on the resorption and then removal. Oligohydramnios, on the other side of this coin, is less than 0.4 liters of amniotic fluid. And this is going to be associated with placental insufficiencies or small placenta, renal malformations including agenesis or obstruction, and pulmonary hypoplasia, because this will be a sign that the inhalation of the amniotic fluid won't be happening. Oftentimes, having small levels of amniotic fluid will put more pressure on the infant within the amniotic sac and will put pressure on the face, limbs, and umbilical cord because of the uterine walls, especially once it starts contracting during Braxton Hicks preparatory movements. It also is thought to play a role that some of the oligohydramnic involvements will actually make a person or a fetus more susceptible to getting amniotic banding syndromes. As far as an amniocentesis, you'll need to be aware of when and what an amniocentesis is used for. It's basically when you pass a needle through the lower abdominal wall and enter the uterine wall into the amniotic cavity, where you can withdraw some of the fluid for diagnostic purposes and cell culture. You can also measure alpha-fetoproteins, which we've discussed are often high with CNS disorders and low with things like Down syndrome. Now, the CNS disorders, anencephaly, will also be high in alpha-fetoproteins for things like gastroschisis or body wall protein folding issues that we'll discuss in a few moments. What kinds of placental problems can you have? Things that you need to be aware of for your USMLE preparation are things like placental abruption. This occurs when there's separation from the chorionic plate and the endometrium, and it oftentimes is because of blood clot formation or hydrodissection that occurs as a result of tearing away of blood vessels that will then leak into the layers of where the placenta is implanted. This can very often lead to fetal death. Placenta previa we've mentioned slightly, as the cervical os gets covered because of implantation too close to the internal cervical os. And again, this is susceptible to early pregnancy bleeding. They can carry to term, but these people are oftentimes the ones that are suggested by their physician to be flat on their back for the later stages because of the risk of placental abruption that can occur as a result of being placed near the cervical os and the pressure that the fetus applies to that. Placenta accretia is through the over-implantation of the placenta, where the invasiveness of those syncytial trophoblasts will eat into the myometrium itself, which is very vascular. And once this has invaded into the myometrium and has gone beyond the endometrium, the baby will be delivered, and it will have very heavy hemorrhaging and require a hysterectomy. These will all typically present with vaginal bleeding, especially during the second trimester as the size of the fetus and the weight of the fetus starts to become more prominent. Accretia is the one that's going to have some very massive and potentially fatal effects on the maternal side, as well as for the after delivery. The placental placement is typically, as we'd mentioned, noted by ultrasound and as a regular part of the screening program with prenatal care. Let's move to another question. A 27-year-old female mother of twins delivers a fetus with severe edema, jaundice, and hepatosplenomegaly. She did not receive prenatal care and you suspect isoimmunization has occurred. You immediately check her blood type and she's found to be O negative. The father is known to be O positive. What is the blood type of the fetus? The answer here is O positive. The important part about this question is that you recognize that isoimmunization has occurred through the placenta, and this puts the mother at risk, since she is O negative, of rejecting the fetus and producing antibodies against the fetus. She's already delivered twins, which would suggest that she is at a high risk of having these antibodies already present. Let's discuss isoimmunization a little bit and the placental barrier. As is the case with this Rh negative factor, the second pregnancy is always the more severe of the two because of the maternal memory of the immune system of the mother. The placenta really, in theory, should be a barrier, but it's often not a complete barrier, and will have micro-traumas and tears during the pregnancy, which allows the isoimmunization to occur. The Rh antigen is going to be dominant, and the fetus must therefore have the O positive blood that the father had, and therefore this fetus is at severe risk. The IgG are going to be made against the Rh, can cross the placenta and then destroy the red blood cells of the fetus, which is going to cause general liver and spleen failure and hypertrophy from erythropoiesis that's going on. Typically, jaundice would be a result with the accumulation of the bile pigments, and now this has been fairly well recognized and can be treated with RHD immunoglobulins prophylactically as long as the mother is getting good prenatal care. So let's look a little bit further at the organization of the placenta as a barrier. It is, in theory, supposed to be a placental membrane that separates the fetal and maternal surfaces. It will have the connection via the umbilical arteries and the placenta itself. Remember, the umbilical arteries are carrying deoxygenated blood from the fetus, and the umbilical vein is carrying oxygenated blood back to the fetus for gas exchange to occur at the placenta. And that will occur within the intravillous spaces where maternal blood is emptied into that space, and the fetal hemoglobin has a high attractance to oxygen and will take it from the maternal red blood cells. Therefore, the lungs and kidneys of the mother are going to be responsible for cleaning and filtering and reoxygenating the blood so that it can be sent back through those spiral arteries, which will open up into the intravillous space. The placenta is going to be an important clearinghouse for waste products such as carbon dioxide, water, urea, uric acid, and bilirubin, as well as some other things like RBCs, antigens, and hormones that we've discussed in the previous case. There are several things that you do want to cross the placental barrier. Water, carbohydrates, amino acids, lipids, electrolytes, hormones, vitamins, and iron are only a few of the things that are regularly crossing. Unfortunately, there's also many harmful substances that can cross, including alcohol, poisons, carbon monoxide, which highly affects the fetus because of the attraction to carbon monoxide being higher, just like it is with oxygen. The viruses, including rubella and cytomegalovirus. You can have radioactive substances such as strontium or Toxoplasma gondii, bacterial infections. Other substances that will cross readily will be antibodies, IgG, vitamins, and transferrin. Things that will not typically cross will be some of the very large bacteria, heparin, IgS, and IgM components. A question that will be a high yield is to understand how insulin-dependent diabetic mothers during their first pregnancy will be concerned that they'll have an injection of insulin that will cause malformations. And as an astute physician, what would your advice to this person be about the insulin and how it relates to the blood-placenta barrier? Hopefully you'll recognize that insulin does not cross the placental barrier. This is an important point for you to know going into your boards because there's a very high chance with diabetes being so prominent in the U.S. today that this is going to be a question that could be asked on the boards. Concludes portion 3 on placentation. The next segment that we'll deal with will discuss twinning through the process of neurulation.